hear me and see the screen? Okay, so this actually is another Sarah Hurwitz poster, excuse me, oral presentation, but she didn't give it, and neither did I, but we're both authors on this, and we both participated in this. And it's kind of exciting that it got elevated to the level of a late-breaking abstract. And, these are tough studies to talk about because they're so niche. This is a study looking at
Oh, nice.
multi-targeted
I heard
therapy,
about this
and
one.
we struggled with accrual to this, but it's a very interesting study of what we're going to call Zani here, zanidatamab, and in combination with endocrine therapy and without any cytotoxic therapy for people who've had at least a line. And I'll go on to get more specific about who was enrolled. So this was presented on Friday. These are the disclosures of the group, which are many. And what's interesting is this all started out with Zymeworks, a local Seattle, well, really Vancouver company, but was sold to Jazz and Pfizer. Okay, so very interesting targeted agent looking at an antibody that binds to a novel for us binding sites of HER2. So not this is not trastuzumab, not pertuzumab, and not like other antibodies. And so they thought that since they had such a good agent to target HER2 with, if they could partner with good ER targeting, could we avoid cytotoxic therapy in these patients who generally are managed with
Oh,
cytotoxic
no, those are
therapy?
the old ones. Those are the new
Hey,
ones.
Jane, could you mute?
Oh, sorry.
So um this was a phase two study. So really, this agent hasn't been given to that many people, and patients who had a normal performance status and had been treated with appropriate first line therapy, meaning Trastuz at least. And then one of these other types of targeted agents were required. CDK4/6 inhibitors were previously were excluded, but that's also not standard of care. We unfortunately had a competing study that got in the way of accrual to this study. Um, and stable brain mets were allowed. And so the treatment on this study was Zani and Palbo, standard dose Palbo and standard dose fulvestrant. And what you can see is in terms of who we enrolled, most people had many lines of therapy, up to 12 here. But some had only had one line of therapy. And a multi-center trial with some central HER2 testing and some not. And some patients with brain mets were included, and you can see a list of the prior therapies. So the 6-month progression-free survival was really outstanding. And disease control, DCR, was also outstanding. Everybody doesn't get a complete response. Really only 10% here, but lots of stable disease, lots of partial responses, and few people who progressed. These, I think, admittedly, were cherry-picked patients, but it's still pretty exciting. So is the waterfall plot, beautifully shown that some people got a complete response, many people had a partial response, few people had progression, and some people just had stable disease. If you drill down and look at what was happening with uh, their HER2 status, you can see that the stronger HER2 positivity was associated with a stronger response. Um, and hang on. Yeah. They also looked at PAM 50 subtyping in these patients, and not surprisingly, most of them were HER2 enriched, but not all of them. And in terms of toxicity, some of it was really attributed, I think, to the other drugs, but there was some diarrhea and nausea and stomatitis, and that would not normally be seen with just Palbo and fulvestrant. But overall, this was pretty well tolerated and mostly safe. There was one episode of transaminitis that it resolved. So I think this is a promising agent in this heavily pretreated patient population that really did quite well with purely targeted therapy, and is something that could be used in selected patients. It breaks my heart that we don't have a better way to select people for this and get patients on these studies. This was not easy to complete accrual here, but hopefully with multiple changes in sponsorship, this drug can move forward, and hopefully this whole way of treating patients can move forward. We've certainly seen that with other studies in the TBCRC, and we'll be pushing for this drug. But I wanted to run through that quickly because there were a lot of other exciting things at the meeting, and I want to make sure we get to those and have a little bit of a roundtable here with everybody. But of course, happy to take any questions.
Hannah, one of the things that we noted in that study was the high rate of discordance from local testing and central testing. There was a big group of patients who were centrally not confirmed to be HER2 amplified, which is a little unsettling as they go and develop a larger study. So there's a lot of discussion about, now Mike Press did the central testing for this study. So it was one lab and truly a premier laboratory looking at it, but it really does call into question, the importance of doing the testing. And the patients had a median PFS, like you said, of 15 months if they had centrally confirmed HER2 positive, which is pretty good after 4 prior lines of therapy. So this study will be coming to us. The studies in development, they're designing studies that may be looking at the maintenance phase after TDXD in the first line setting, because patients wouldn't do well on TDXD for 5 years probably if the Destiny Breast study leads to TDXD being front line. So maybe looking at doing induction with TDXD and then maintenance with this well-tolerated therapy. So I think Jazz is now in control of this drug and is open to a lot of input, and I think maybe there will be opportunities for us to contribute on a leadership level in this study. One of our young investigators.
Well, just to plug one of our young investigators, Tasha Hunter has looked back at our data here, and I think you're bringing up this whole issue of heterogeneity, and I think heterogeneity with HER2 positivity is one topic, but what we've looked at is in the ER positive patients, whether or not there's good ER expression in the patients who are also HER2 positive. And what's interesting is there is strong ER positivity, and that would be the population I would cherry pick for this study. And that was actually the reason I signed up to do the study, is I wanted to cherry pick using that method. And of course, that was a bait and switch, and they were not unwilling to fund that. However, I think we should try again because this is really important. I think there's too much toxicity for these agents. I think with regard to the HER2 heterogeneity, there's sort of a couple different issues there. There's, does it change over time? And there's what tissue did you sample? And, what we've seen historically is that actually sometimes it's that the central testing is done on a different piece of tissue than the original testing was done. And that there's actually intra-patient within a patient, there's heterogeneity of HER2 expression. So this is complicated. And I wish I could tell you we have a HER2 agent that could pick out a tracer that we could pick patients out with, but that's not ready for prime time.
Right. Well, thank you, Hannah. I had raised my hand, but you said exactly what I was thinking, and that I think we have potential expertise to be able to think about using our biomarkers to help select patients for whom this might be a phenomenal opportunity to have a nice maintenance strategy. And having said that, I see, Sarah, obviously you're on. I wonder if you are okay to go next. I know you have another
Yes.
commitment. So
Absolutely.
I think you should be able to share your screen.
Okay. All right. And there we go. And there we
Mm.
We saw your screen, but then it went off.
Yeah, I'm worried we lost Sarah.
I think we did lose her.
Mm.
Oh, she's back on.
Okay.
Yeah, so my computer just shut down.
Mm.
I'm not sure why. So let me.
It was looking promising.
It was
Yeah, we could see it.
I know, and something just didn't go. So let me pull up on this screen here. Sorry, everyone, I have to use a different computer. So the study that I am going to be presenting is the HER2CLIMB trial, HER2CLIMB 02. And I now have it up. So, and this is a study looking at TDM1 plus, okay, now I can't share it. All right. Does somebody have the slides they can pull up? I have to shut down Zoom.
I wonder, Janice, is it possible that you might be ready? Maybe we could
Yeah, that would be great. And
Yeah,
I'll
you
give
bet.
it to Janice, and then come back and we'll try to get you in, Sarah, before your meeting.
okay, sounds great. Thank you.
Thank you.
Okay. I am not tech savvy, so give me a second here. Okay, do you guys see my slides? Okay, you might see my presenter view. I'm not that talented with this stuff, so you might just see my notes, okay? All right. Well, good morning, everyone. I'm Janice. I'm a radiation oncologist here. So San Antonio typically is a medical oncology heavy conference, but they always have some wonderful gems for us local regional folks. And this year was no different. I'll be talking about the IDEA and the NSABP B51 studies. I think that these are two big studies. A lot of it is with radiation right now is with de-escalation and really trying to tailor our treatments to patients that may not need everything. And I think these studies really are some very promising or show some promise to that. All right, so this is the IDEA study. These slides are courtesy of Dr. Reshma Jagsi. So I'll be talking about the 5-year outcome of the IDEA trial of endocrine therapy without radiation in the setting of breast conservation for
Hey, Janice.
Yeah.
Janice, this is Ben. And
Oh, hey,
if
Ben.
you use slideshow, if you see that in the upper left, I think if you hit that, it will fix. There you go.
Okay.
Thank you.
Okay.
For
How
my
do I
aged eyes. That's great.
Okay. Thanks. So I might have to switch back. There's some notes that I took. I don't know how to show but you know what? That's okay. I'll just kind of wing it. Okay. But basically this is a study of 5-year results of endocrine therapy in patients who had undergone breast conserving treatment in patients who are 50 to 69 years of age and are postmenopausal. We all know that there's robust data in terms of radiation and lumpectomy. The meta-analysis showed this. However, we also know that there are going to be some cohorts that are going to benefit from radiation way more, glean a bigger benefit than others. So along that vein, here are 2 studies that many of you are very familiar with because us radiation oncologists always mention it. These are the elderly studies. They are of women who are 65 and 70 years and older, and because these are patients that often present with very favorable tumors. And what they found was we can safely omit radiation as long as they do the 5 years of endocrine therapy after breast conserving surgery and still have pretty good local recurrence or local control. Interestingly, the Canadians did a similar study around the time of the CALGB. I find it a little offensive because they considered these elderly patients older than the age of 50. But be that as it may, they looked at these patients, did similar things, omitting radiation, after surgery. And what they found was that for patients, omitting radiation in this younger cohort actually was not, didn't achieve the same excellent local controls that we saw in the PRIME 2 and the CALGB trials. Well, we get to a point where we're slowly realizing that clinical and pathologic features may just not be enough in terms of helping us really tailor and guide our local treatments. And so we started looking at genomic assays. And this is a study from Dr. Mamounis, basically using the 21 gene assay to maybe help us discriminate better patients where we could safely omit radiation. And so with all this in mind, that's where the IDEA study came about. This was a prospective multi-center study, the first to use the genomic assay in patients who are younger, so patients ages 50 to 69 who are postmenopausal. They had to have unicentric invasive breast carcinoma. They all underwent lumpectomies. Sentinel procedures or axillary evaluations were mandated on this study. You can see the criteria very, very favorable. They had to have a recurrence score of less than or 18 or less. They were then consented and registered. No radiation was given, and they were on 5 years of endocrine therapy and then 10 years of surveillance. This is just a breakdown of the patient characteristics. Again, very favorable, mean age of 62, small tumors, low recurrence scores 11. MRIs were taken in or obtained in about a third of the patients, but again, very, very favorable folks. And what we found was that with a median follow-up of 5.2 years, at 5.2 years, 186 patients were able to be evaluated. And what they found was that the overall breast cancer specific survival rates or overall and breast cancer specific survival rates of 5 years were both 100%. 5-year freedom from any, I'm sorry. A 5-year freedom from any recurrence was 99%. And just to let you know, this is very favorable data from the IDEA study, but there are additional studies right now that are using the genomic assays. So not just the clinical and pathologic features, but there are others that are using genomic assays and other molecular testing to see if they can safely tailor our local regional therapies. And hopefully we will have more information in terms of how to use the genomic assay to help guide our local regional treatments. So in conclusion, for the IDEA study, the 5-year 5-year risk of recurrence using the genomic assay in combination with the classical, clinical and pathologic features for women that were younger the age of 69 and postmenopausal, I think that it's something to think about. And I think we could possibly omit adjuvant radiation in this group. I do think that longer term follow-up in this trial is going to be important. Give me a second, I think. How do I go back? Okay. One thing, for some reason this slide got skipped. Of the results from the study, again, at 5 years, the number of local recurrences were quite low. There were only 2 patients that had recurred. One was an isolated ipsilateral axillary recurrence at 21 months. The other was an ipsilateral breast event at 49 months. But interestingly, after the 5-year follow-up, there were 6 additional patients that had recurred. Of those, 5 were ipsilateral breast events. One was an ipsilateral breast event plus a regional recurrence. Again, after 5 years of follow-up, after 5 years of endocrine therapy. There were no distant recurrences observed on this study. Overall, I think that looking at the compliance of endocrine therapy, because I think that's a big thing that we talk about. We know that anywhere between 30 to 50% of patients cannot tolerate the 5 years of endocrine therapy. Well, on this study, 169 patients were compliant with endocrine therapy. Out of the 200 and some, both patients who recurred before the 5 years were compliant. So the 2 patients that recurred before 5 years were on the endocrine therapy for 5 years. But for those who recurred after the 5 years, only half of them were actually compliant on the endocrine therapy. So again, I think long-term follow-up of this trial is really needed to determine whether we can really avoid initial radiotherapy, and that can be offered to a broader group of women when current guidelines are recommended. Such efforts to, trying to strive to really tailor our treatment and use different features, clinical, pathologic, and genomic, I think is at the end of the day extremely important and empowering for our patients when they make their decisions. Just to put in my little editorial, though, I think just some food for thought. I think it's an excellent study. I think all of these are excellent studies. I do wonder, though, I guess my question to the group would be, what is the big what is the big deal to giving radiation? We are now at the point where we're offering 5-day treatments. So that is logistically and financially maybe a lot more tolerable than what we used to do when we used to give, 6, 7, even 4 weeks of radiation. We're now able to offer 5 days of treatment, whether it's on the fast forward per the Brits or as partial breast treatment, which again, both of these techniques offer extremely low toxicities for patients, both physically, financially, logistically. And so I guess for me, I am excited to see the results from all of these studies to see where we can omit radiation, but knowing that potentially the compliance rate on endocrine therapy is not as robust, maybe we can still offer radiation and do it in a way that's thoughtful and less toxic. All right, I'm sorry, I don't know how much time I have, but I'm going to go on to the next topic, NSABP B51. These are slides that are courtesy of Dr. Terry Mamounis. We are as an institution, very familiar with this study as we did enroll many patients onto the NSABP B51 study. This was a study of local regional radiation in patients who were clinically node positive and then rendered node negative after neoadjuvant chemotherapy. Their radiation was de-escalated, and the 5-year results were presented at San Antonio. So some background for patients who undergo upfront surgery and are found to have pathologically positive axillary nodes, the benefit of adjuvant regional nodal irradiation, including chest wall and regional lymphatics, or when added to whole breast, is well established. And we have lots of information on that, the meta-analyses and such. However, when patients who present with clinical node involvement and then receive neoadjuvant chemotherapy and then are pathologically node negative at the time of surgery, they are often found to have lower local regional recurrence rates compared to those who have residual nodal disease after pre-op chemo. So this was a phase 3 randomized trial where we evaluated whether chest wall and comprehensive nodal irradiation after mastectomy or whole breast irradiation with comprehensive nodal irradiation after lumpectomy significantly improved invasive breast cancer recurrence-free interval in clinically node-positive patients who were deemed pathologically node negative after pre-op chemo. This is just a schema. Many of you, again, are very familiar with this. Those who were enrolled were the T1 to T3 patients with N1 disease. So again, node 1, so minimally node positive, N2, N3, the more locally advanced disease patients. We know that adjuvant radiation is still a pillar of treatment for those patients, regardless of their pathologic response. But for these were for patients with minimal nodal burden. They all were found to have clinical node positive disease up front. They all underwent neoadjuvant chemotherapy. They then underwent surgery, whether it was lumpectomy or or mastectomy. At the time, sentinels and axillary lymph node dissections were allowed or were possible options on the study. But after Dr. Bowie's study, most people started doing sentinels. They were then, if they were found to be YPN zeros, they were then randomized to either no regional nodal irradiation. So for patients who underwent lumpectomy, it would be breast only. For those who underwent mastectomy, no radiation was offered, no post-mastectomy radiation, versus the more standard treatment, which was regional nodal irradiation. So for patients who underwent lumpectomy, it was breast and regional lymphatics, or if they underwent mastectomy, it was chest wall and comprehensive nodal coverage. The primary objective of the study was to evaluate whether the comprehensive nodal treatment improved invasive breast cancer recurrence-free interval in, again, clinically node-positive patients who were then later found to be node negative after pre-op chemo. Secondary objectives you can see below there: local regional recurrence-free interval, distance-free, disease-free overall, and toxicities. This study was open between September 2013 to December 2020. Overall, 1,641 patients were randomized. There were some exclusions. Overall, 1,556 patients were analyzed for disease-related endpoints. And they were pretty well distributed. 784 patients received no regional nodal irradiation, while 772 patients did receive the comprehensive nodal coverage. Median follow-up time was 59.5 months. These were some of the characteristics, baseline characteristics of the patients, very well distributed. You got some younger patients, older patients, clinical tumor size. Also, subtypes were pretty well distributed as well. The triple negatives, triple positives, hormone positive, HER2 negative, surgery, as well as the different surgeries were also very well balanced. The majority of patients did have a path CR in the breast, but of note, you could have residual disease in the breast on this study as long as the nodes were clean. And I think a very small group of patients received additional chemotherapy afterwards. I'm not sure why, but they did. So for the results, the 5-year results showed that invasive breast cancer recurrence-free interval, no difference, whether you gave comprehensive nodal irradiation or not. Isolated local regional recurrence-free survival or interval, there was no difference in the 2 arms. And as you can see here, the breakdown of local versus local regional, it's very small events in this group, in this population. Distant recurrence-free interval, again, as you can see, the lines are pretty much overlapping at 5 years. Same thing with disease-free survival, overall survival. And also I forgot to add, in terms of toxicities, there's not much of a difference in toxicities. The biggest one obviously was radiation dermatitis, but that seemed to be very evenly, or was very expected, and there were no significant toxicities with the comprehensive nodal radiation. Here is a forest plot of the results. There was no, as you can see here, there's not much in terms of big differences, whether the patient had breast-conserving surgery, mastectomy, hormone status, whether they had a PCR in the breast, or if they received adjuvant additional chemotherapy. This is a breakdown of, age, race, tumor subtype, and whether, the type of axillary surgery. Again, no clear, obvious distinction between favoring comprehensive nodal irradiation or not. However, of course, I kind of I'm always one to kind of look at these things a little bit more carefully. This was a little confusing to me. The triple negative patients, it appeared that they favored no comprehensive nodal irradiation, while those who were ER positive, PR positive, HER2 negative, they favored nodal irradiation. Of course, I get it. There's very few events that probably skewed the statistics, but that also makes me think that maybe we do need to wait a little longer, more than 5 years, just to make sure that we do feel comfortable with kind of allowing this to be, go prime time. So in conclusion, in patients who present with biopsy-proven axillary nodal involvement and then are convert to negative nodes after pre-op chemo, we don't think that comprehensive nodal irradiation really did much in terms of improving 5-year results. I think these findings suggest that downstaging involved axillary nodes with neoadjuvant chemotherapy can optimize adjuvant radiotherapy use without adversely affecting oncologic outcomes. But I agree. I think we do need further follow-up, long-term outcomes to really feel comfortable and maybe make a paradigm shift. Thank you.
Great. Well, thank you, Janice, for presenting these 2 pretty important studies. I think because we do have some time commitments, we might keep moving, and hopefully maybe we'll adjust at the end for some questions, if that's all right. I think Dr. Young is going to go next, and then awesome, she's ready to go.
Okay, I'm going to talk about, in particular, the NATALEE and the positive trial, and I'm going to focus a little bit more on the NATALEE trial because I think that has more implications for us. The positive trial is secondary aims, and so we'll spend a little bit more time on the first. So the Natalie study was our adjuvant CDK4/6 inhibitor ribociclib study, which we have at our institution as well. It differed from some of the others in that it allowed in lower risk disease. So this did allow in node negative disease, and that'll come up later as we're talking about it. Of note, that node negative disease either had to be grade 3 or grade 2 with some other high risk component, Ki67, Oncotype DX, or other genomic profiling, or node positive disease. This was also a little bit different than the other adjuvant CDK4/6 inhibitor studies in that it used the middle dose of ribociclib, really hoping to decrease the toxicities. And it looked at it for 3 years versus Palace and Monarchy that looked at 2 years. It only looked at non-steroidal aromatase inhibitors, so letrozole and anastrozole. And it included both men and premenopausal women, but they had to have ovarian suppression. The presentation was the final analysis of the IDFS, and that's what I'm going to talk about here.
Just in hold charge, or
Are
they just not in charge?
And I think you're not muted. IDFS is shown here for the whole cohort, and it shows, so I'm going to make this smaller. There were median follow-up was 33 months with a maximum of 51 months. And it showed that there was, I tried to put some of the key things in red. So if you guys want to focus in on that, I realize you're getting a lot of information. So the red kind of gives you the takeaways. 3.1% absolute benefit at 3 years with ribociclib. And this correlates to a 25% reduction. We see the hazard ratio right here is 0.75. I'd like to point out, and we can talk about the nuances of this, that it met the final protocol specified events of 500. That's why the analysis was done. And I think that many of us are just a little bit nervous about this being right at 3 years and having median follow-up for 33 months, given that it's given for 3 years. However, about 76.9% of the patients were already off of ribo at the time of analysis. So this is just the forest plot. And the reason why I'm showing this is because you see that it's pretty consistent across all of these subgroups in terms of the hazard ratios. And then I wanted to show it by nodal status. And what we see is that the hazard ratios are pretty similar versus if it's node negative versus node positive. We do see that there's a slight difference in sort of the absolute benefit, with more risk having a slight increase in absolute benefit. We see this is true if we look at the stage 2 versus the stage 3, and this is maybe even a little bit more pronounced. We see the hazard ratios again are pretty similar at that 0.7, between 0.7 and 0.75. However, you see that in the stage 2 group that the absolute benefit is about, it's just under, it's like 1.5 percentage points, whereas it's almost 4.5 for the stage 3. And I did that math fast, so if I'm wrong, it's okay. And then I just wanted to point out what the safety profile of ribociclib is. And I think that, you know, we've known this for a while, but I think that the more we're using it in the metastatic setting and other things, that some of these things come out. The most frequent side effect really is this liver-related AEs, and that was actually the most frequent reason for discontinuation. And notably, I didn't actually see it much in my patients that were on the Natalie trial, but I have seen it a lot more in the metastatic setting. And then other things that are unique to it are the QT prolongation and then this ILD that we see. The rest of the side effects are pretty similar. And then I wanted to show the distant disease-free survival. I think that, you know, this is kind of where the money is, and this is where we think about, you know, these are women who are actually going to be saved of incurable metastatic breast cancer. And we see that it has a similar hazard ratio as for the IDFS at 0.79 again. And this is statistically significantly improved. We see a difference of almost 3% here. overall survival is, we don't see an overall survival, but data is immature, and that's what we would expect, given that even in the metastatic setting, we see, median survivals are over 5 years. So we're just not going to have that data here. So cross comparison or cross trial comparison for what it's worth. And I realize that this is fraught with issues, but I just wanted to put it out there because I think that many of us are having to make this decision and think about what we might do. I will point out that ribo is not yet FDA approved, although when I was talking to colleagues across the country at San Antonio, many of them are getting ribo in the adjuvant setting already. And abema, we see that, either you have to have had node positive disease. 40% of that was node, was N1, 60% was N2 to 3. So this is a much higher risk population. This actually wasn't segregated out in this data. So node negative disease was 12% and node positive disease was 88%. So this could be separated a little bit so that we could understand how it compared to this a little bit better. Length of treatment is 2 years versus 3 years, 150 milligrams BID, which is the highest or standard dose. 43% of those people were dose reduced. For ribo, it's the middle dose, and it was 400 milligrams BID. It didn't actually state how many were dose reduced, so I don't have that information. For abema, we have the 4-year IDFS, which is 6.4% absolute benefit with a hazard ratio of 0.66. Ribo is, we have 3-year data at 3.1% benefit, a hazard ratio of 0.75. So similar, and maybe even more similar depending on what that risk stratification looks like. The DDFS on both of these, ironically, is exactly what it was for the IDFS. So it's 0.66 here and 0.66 here. They're not actually the same numbers, but they rounded to the same hundredth space, and 0.75 for both of these. And I just wanted to point out what the side effects look like. Just talking about sort of the difference, diarrhea up to 80%. That includes grade 1, and much of that's very tolerable, but it is a very prevalent side effect. VTE of 1%, creatinine elevation of 11%, and that causes a lot of back and forth for patients. LFT abnormalities is 10%, which is not actually much different from the ribo. QT prolongations here, and ILD is noted here. I think some of these things that are at 1%, if we had more data, we might see them, and there were cases of pneumonitis and abemaciclib. There is actually one fatal. Some real world considerations. Abema is only in the node positive population, and I put this $ just to denote financial toxicity. This is both for patients, institutions, and what we've already experienced in terms of how this affects our how much treatment patients are getting and attention they need in the adjuvant setting for our ER positive patients. So really increasing that. This isn't yet FDA approved. It's a longer treatment at 3 years, and again, financial toxicities. So I just say that the studies, the Natalie study really showed benefit, and the relative amount is the same across the groups, but there's more absolute benefit for a higher risk disease.
So that stack on this group, that's fine.
Secondary results from the positive trial. So this was a trial, or this was a presentation, which is really the secondary results. It was looking at fertility preservation and assisted reproductive technologies of the positive trial. So the positive trial was presented, I don't remember, a year ago or so. And this is what it is. It's a prospective international multi-center single arm trial, and it's really looking there. Here are the key eligibility criteria. So premenopausal women stage 1 to 3 with hormone receptor positive breast cancer, that they want to become pregnant, that they are less than 42 years of age at study entry, that they have received between 18 and 30 months of prior adjuvant endocrine therapy, and that they have no evidence of recurrence. So this is what happens before the study. They stop endocrine therapy. They have a 3-month washout. They have up to 2 years break to allow for conception, delivery, and plus minus breastfeeding. So that actually includes that 3 months of washout. And then they resume their endocrine therapy for the follow-up period. So these are prior positive results, and this was published in New England Journal of Medicine, Partridge et al. In 2023. And I didn't give the whole table here, I just gave the ages. So we see this is the control group, this is the group that underwent treatment interruption, and this was a smaller number than the number who actually were in the trial. I think that this is actually the women who actually conceived. So we see that we see higher numbers in those who are younger, as opposed to the cohort control cohort. And then these were the pregnancy outcomes that happened. So of the women who attempted pregnancy, 86% had a live birth. 80% of those were full terms, 7% were preterm, 25% miscarried. And these numbers don't add up because some of these women factor into multiple categories. A few elective abortions, stillbirth, and neonatal death. So just putting that out there so you have that. This is the, again, still prior positive results, putting it in your mind so you have it, so that we can talk about the other results. We see that that they're essentially in the cohort and the treatment interruption group have very similar cumulative incidence of breast cancer events. And then distant recurrences are very similar as well, where you see actually the treatment interruption group is slightly lower than the above group, probably because of residual confounding in this non-randomized trial. So going on, these are the actual results that were presented at San Antonio. And this showed, talked about menstruation, resumption. So how long did it take for women to resume their menses? And I think that this has some implications for us, just in terms of the corollary I pointed out, is just it gives us a little bit more data to inform discussions about OS in the adjuvant setting as well. So, if you stop your endocrine therapy, they all stopped within a month of study entry. And 53% of women were amenorrheic at the time of enrollment, and 94% of those women under 42 resumed menses. So that is really quite remarkable. We see that women who did not have any chemotherapy or GnRH agonist, well, that's actually not true. You could have had OS, but no chemotherapy. They're here in the dotted line. If you had chemotherapy with a GnRH agonist, so with this thought of ovarian protection, you were here in this blue and slightly better numbers, and then chemotherapy without GnRH has slightly lower numbers. And then this is time to pregnancy, and they did a multivariable analysis trying to find out if anything else mattered, but really age is the only thing that matters in terms of how long it took people to get pregnant. They did look at chemotherapy or chemotherapy alone, chemotherapy with the GnRH, chemotherapy versus no chemotherapy, which is really notable that chemotherapy wasn't an effect in terms of time to pregnancy, or your endocrine therapy. That didn't seem to matter. So it's really age. So less than 35 years old, and you have a much quicker time to pregnancies. Older, less. Oldest, less. And then another question that comes up is ovary stimulation safe during pregnancy? You have surges in estrogen, and what does that do? And so this is looking at ovarian stimulation and breast cancer outcome. And this was part of, as part of embryo and oocyte cryopreservation after a breast cancer diagnosis. So these are the women, this is 3-year breast cancer-free events. And this is, it was 9.7 for those who underwent ovarian stimulation and 8.7 for those who did not. So really not seeing any difference in women who had ovarian stimulation. And so the conclusions here from the positive trial are that more than 90%, 94% of women presenting with amenorrhea resumed their menses, mostly during the first 6 months. that young age was the main factor associated with a shorter time to pregnancy, whereas the type of endocrine therapy was not. And there was no increase in the breast cancer events was observed in patients undergoing IVF on the study, albeit there were very few events and longer follow-up is needed. And just to say that this data is imperfect as we knew it would be, but it really is the best data that we have to discuss this important issue with our young patients. And I'm going to stop share. Thanks, guys.
Thanks so much, Rachel. It's really encouraging to see the data, particularly on IVF and fertility treatments. So thanks. Sarah is up next.
Yes, and I am hoping that there will not be any issues with my computer shutting down, so it's looking promising. All right, I'm going to go through this relatively quickly. This is the HER2CLIMB-02 study to leave a little bit of time for discussion. And here are my disclosures. We know tucatinib is a highly selective TKI for HER2 positive metastatic breast cancer, already approved in combination with capecitabine and trastuzumab based on HER2CLIMB. TDM1 and tucatinib have been looked at in preclinical models. There was a phase 1 study done by Ginger Borges that showed the combination of TDM1 and tucatinib was safe and had some anti-tumor activity, including in patients with brain mets. And so for this reason, the HER2CLIMB-02 study was designed where roughly 460 patients were randomly assigned to TDM1 with tucatinib or placebo plus TDM1. Patients were allowed as long as they had had trastuzumab and a taxane in any line setting. Similar to the HER2CLIMB study, those patients with brain mets were allowed, and that included patients with active disease. The primary endpoint was PFS by investigator assessment, and the rules were if the primary endpoint was met at the primary analysis, this would trigger the first of 2 interim survival analyses to be done. The other key secondary endpoints are shown here. The groups were well balanced. Interestingly, about 43% of the patients had a history of brain mets, half of whom had active brain metastases, and about 44% of patients had de novo metastatic disease at the time of their initial diagnosis. This was a global study with a worldwide enrollment of patients. Median of 1 prior lines of therapy in the metastatic setting, up to 8. Interestingly, the vast majority of patients had received prior pertuzumab, and it should also be noted that no patients were allowed who'd received prior tucatinib, nor were patients allowed if they'd received prior TDXD. So this study was not set up to look at the activity of this regimen post-TDXD. Also, of course, it wasn't comparing TDM1 tucatinib to the FDA-approved tucatinib regimen. Here's the primary analysis of PFS. It was a statistically significant improvement with tucatinib TDM1, absolute benefit of about 2 months, hazard ratio 0.76. Again, this triggered analysis, the first analysis of overall survival, which I'll show you in a moment. The subgroup showed fairly similar outcomes and benefit from tucatinib, perhaps with the exception of patients with a performance status of 1. And if you look at those patients without baseline brain metastases, the overlap with the null point is fairly certain. This was a non-statistically tested analysis of PFS in patients with brain mets due to the hierarchical testing rules. There was a strong trend, and the hazard ratio here is 0.64. And again, a very similar benefit of a PFS, absolute benefit of just over 2 months, although both patients in both arms did worse who had brain mets, which is not unexpected. Objective response rate also not formally statistically tested, but trending toward better in the tucatinib arm. Subsequent therapies were received by the majority of patients on this study after coming off study. It is notable that around half of the patients went on to receive TDXD, which we know has remarkable benefit and activity in this setting, which may be why the observed survival events we're seeing are not even close to being mature yet. Additionally, about 15% of patients went on to receive tucatinib in both of the treatment arms. Overall survival was not statistically significantly different at this interim analysis, at which point only 53% of survival events have been observed. It's interesting to note the overlapping nature of the curves up until 18 months and then a high amount of censoring after that, which may lead to this perceived flipping of the curves in favor of the control arm. The statisticians have indicated this past 18 months, we really can't rely on the data. So we're going to have to wait until the second interim analysis is triggered when 80% of events have been observed. In terms of safety, adding tucatinib to TDM1 did increase the rates of grade 3 or greater adverse events, not unexpectedly. There were also higher rates of discontinuation of both drugs in the tucatinib arm. And we saw the major things that we saw were patients having transaminase elevation. You can see the types of AEs experienced in the blue columns are the tucatinib arm, and you can see higher rates of nausea and diarrhea, fatigue, vomiting, transaminase elevation, with the transaminase elevation being grade 3 or greater in about 16.5% of patients. The adverse events of interest shown here on the left are hepatic treatment emergent adverse events, and on the right, diarrhea. The hepatic events, there were no Hy's Law cases observed, which is a good thing, but we did see grade 3 or greater rates of AST/ALT elevation, though when the treatment was held, it tended to return to grade 1 with a median of about 3 weeks to return to grade 1. And diarrhea also, if you look at the rate of 4.8% grade 3 diarrhea, that favorably compares to HER2CLIMB, where that grade 3 diarrhea rate was higher. And again, no grade 4 events in either arm. So here's the conclusions. Statistically improved PFS in the intent to treat population by adding tucatinib to TDM1. There was a strong trend in the patients with brain mets. Questionable how much benefit in the patients without brain mets. That wasn't presented. We didn't present the intracranial objective response rates. The overall survival data are not significant at this point. They're immature. The adverse events are notable. They're different than we saw with HER2CLIMB. And if this becomes an approved regimen, which it is not yet, we will have to watch the hepatic events carefully and hold or dose reduce patients with this. It's unclear to me if this is going to be approved or if the regulators are going to want to see a second survival analysis. And this doesn't address the question of how it compares with the HER2CLIMB regimen, nor does it address how active this regimen is, which is an ADC-based regimen after TDXD. So a lot to be sorted out before this becomes a regimen that would be used clinically.
Terrific. Thanks so much, Sarah. I realize we have a lot to cover and not as much time as I hoped for questions in our last presentation, but we will move forward to January. But in the time we have, I guess, are there burning questions? Please come off mute, and happy to chat.
Hi, Jen, this is Ben. I have one question, which is kind of simple-minded. It goes to Janice's part. So here we have this situation where we might be able to avoid radiotherapy in well-selected patients if they take their endocrine therapy all along.
Right.
But there's an order problem there because you may not know how toxic endocrine therapy is going to be until you've gone through it.
Right.
And so is there a way of testing, sort of beta testing, how are we going to do with our endocrine therapy to find out how miserable they're going to be so that they can make a decision? Has anybody thought about some sequence that could do that? Thanks for considering the question.
Yeah. Ben, I think that that's a great question. And I think logistically, you're absolutely right. Because what I've found is that when patients say, oh, I want to omit radiation, I want to do this endocrine therapy, and then they're not able to tolerate it, they feel badly. And they don't come back and tell the medical oncologist that they're no longer taking it. And they certainly don't come back to me to tell me they're not, that they're not taking it. So now we're in a situation where they've only had surgery, and we have enough data even in patients who are 70 and older, when you just do surgery alone and you have non-compliance endocrine and you don't get radiation, the risk of recurrence can be as high as 20%. So I think it is a problem. And I don't know of any, so what we do at Fred Hutch is because we do try to be a little bit kind of proactive. We usually give a good 12 weeks from surgery. I think that's enough, at least for the radiation oncologist. We feel comfortable that radiobiologically, if there's a delay of 12 weeks, we're okay to still give radiation, still feel that they're in that therapeutic benefit. And that's again based on kind of some of the, cellular, some of these trials that we have. Is that the right answer? I don't know. I would probably ask some of my radon colleagues on here, but that's kind of what we do. We'll say, go ahead and do the endocrine therapy. If after surgery, within 12 weeks of surgery, if you're not able to tolerate it, and thankfully they can tell pretty quickly, then we have them come back.
Just to add, Ben, I think that Janice actually had a proposal for a grant. I think we've gone around a couple times, but have been trying to pilot maybe as a standard practice, actually doing that sort of test drive for patients who might be considering omitting radiation, just so that we can get a better sense of that to help them make the choice.
Thanks.
I would just
Very
add
helpful.
that a second, that dovetails nicely into the question of whether we can omit chemotherapy in our patients by using ovarian suppression, endocrine therapy, or even CDK4/6 inhibitors. So it's a really important question.
And we look forward to BO9 to help us with that key question for our premenopausal patients. And positives, another nice way to loop that in, to think about doing less and helping our young patients maybe refine this a little bit more. So great. Well, my apologies. We didn't quite get to the last one today, but let's plan to meet again in January. We'll go over some of the data with Enolizib and others, and we'll enjoy everyone. Please have a great holiday. Thanks so much, Ben, for joining from afar. Great to see you. And please, everyone, take care and have a wonderful 2024, and we'll see you soon.